So if anesthetic is needed, a choice of prilocaine, since it is metabolized in the lungs and liver, would be a good choice. Another good choice would be articaine. It is more potent, but articaine is mostly metabolized in the plasma and partly in the liver. So those two would be good choices because the others would only primarily be metabolized by the liver. The use of a cardiac dose of 0.04 milligrams of epi would be ideal to use, and that would decrease the risk of a medical emergency since the patient does have high blood pressure. And we wouldn't do any anesthetic until the blood pressure is controlled through stress reduction protocols or with meds. Some contraindications are anesthetics such as lidocaine, bupivacaine, mepivacaine, since these are metabolized primarily by the liver and it could increase the risk of systemic toxicity. I would also ask the patient to get medical clearance from his physician due to his high blood pressure at his initial visit and due to his high alcohol consumption before scheduling any treatment, especially since he has liver disease. So we don't want to do anything to compromise his health and put him at risk for something more serious. His appointment sequence is his first appointment would be SRP on the upper left and lower left quadrant, and then it'll be 90 minutes. His second appointment will be SRP on the upper right, lower right quadrant, 90 minutes. His third appointment will be a reevaluate from 4 to 6 weeks from his second visit, and we'll get new probing done. And then we'll also try to get him on a 3-month recall for period maintenance. So his outcome at reevaluation is that his plaque index at his initial visit was 44%, and now it is at a 15%, so it has improved. Patient has been compliant with oral hygiene instructions given since his last visit. He does have some exposed root surfaces on anterior teeth due to better plaque control now. Arrestin has also helped decrease the inflammation in those posterior teeth or posterior sites, which has increased the attachment levels and reduced the pocket depths. So some examples include on number 4, he had a 5mm pocket and now it's reduced to a 3. On number 14, on the mesial buccal site, he had a 5mm pocket and has reduced to a 4mm. On number 19, all sites were 5mm on the buccal surface and they were reduced to a 4mm pockets. But since they were pseudo pockets and the tissue shrank, there's more recession involved, and that's normal. Here are my sources, and I hope you enjoyed.